Gotcha. All right, and with that, let's lead into the next part of our topic, which is what can we do to increase OrthoK myopia control efficacy in low myopes?
So
Yeah.
I phrase this question this way because, as we all just kind of, I think, came to the decision, a lot of this is theoretical. So none of us are going to sit here and say, if you want to make this better, you have to do this. There is no right or wrong answer here. I kind of wanted to pull everyone here and just kind of get their ideas as to, let's say this is a clinical scenario. You're in clinic and you're treating a patient and they're still progressing, whether it's axial elongation or you're noting refractive changes from what you can measure at least. How do you guys approach this in clinic? What do you do? Do you look at additive therapies? Do you look at modifying lens designs first? How do you guys approach this? Take the lead, Cheryl or Michael, whoever would like to.
I'll go ahead and start off by saying my first approach would be just modify that orthokeratology lens. I assume we're not even talking about soft multifocals here. Maybe if they're in a soft multifocal, maybe I switch modality to OrthoK, but I'm usually going to try to change something within that orthokeratology lens. If you are not fitting a software design lens, that's sometimes where it becomes advantageous to learn one of the software design lenses, because you can do so much more with that and you're not relying on a consultant to help you make changes. I usually like to decrease the overall size of my treatment zone to, like you mentioned a little bit earlier, Jonathan, to try and get more of that peripheral power curve inside the pupillary margins to see if that will have enough effect on the peripheral retina to start to give me what I'm looking for there. Sometimes you can play around a little bit too with the depth of the return zone. That can be a little bit harder because that can start to make your lens too tight. But I really am not opposed either to doing like a combination therapy. So I've got a number of patients that do combo of OrthoK and atropine therapy. If I've already modified their treatment zone size or their OrthoK fit, and I'm still seeing more progression than what I want to see.
But you, Jonathan?
So I tend to be pretty similar. I do subscribe to the idea, at least for now, based on what I'm familiar with, that I want to modify the treatment zone size, as Cheryl mentioned. I'd like to increase the peripheral defocus. I'm fine with increasing asphericity within the back optic zone, as Michael, you had mentioned. Dr. Chow referenced the idea of. I like the idea. Sometimes I run into issues, though, with essentially when you do that, you create too much of a peripheral defocus to alter the refractive status of the patient. So, in other words, it essentially ends up targeting too much, and you end up with a hyperopic overcorrection. So I find that sometimes a limiting factor, but I try to squeeze as much out of the asphericity and the optic zone size changes that I can. Outside of that, then I'm moving to additive therapy as well. So I think I'm pretty aligned with Cheryl.
I think the key point that was made here is that customization is critical, and that we cannot continue to take one standard design, one standard optic zone, and expect it to work for everybody. For many, many years, I may have prescribed only one or two different brands of lenses that had very, very similar designs. And like we said before, some of them worked really well and some of them didn't work as well. Now, at least we have some indicators that are pointing us down the road of decreasing the back optic zone diameter of our designs to help with myopia management.
Yeah.
I had an interesting case too, where I had a patient who, part of the reason I believe that she was a progressive myope was because she had a lot of accommodative issues. She had a high accommodative lag that we measured before we ever started treatment. And she was doing really well in her myopia management But what happened about a year into treatment, and she's getting older, school's getting a little bit more challenging, she's got more homework, she came in with headaches. She's seeing great, axial length's fine, but she's getting headaches. And so what I did with her was adjusted her treatment zone size to give her more of a multifocal effect. And it took care of her headaches like that. And I thought that was really kind of fun and interesting.
Good.
Yeah, that's exciting. I think we all have to keep in mind, kind of circling back to the beginning of this topic, that these are all theoretical changes, but the reality of it is, what else do we have? You know, I mean, we can sit there and just be upset with it, or we can try differences as long as we're still safe. And I mean, OrthoK for myopia control, regardless, is still considered off-label for this purpose. So we're within that realm of still, you know, safely modifying a fit that's FDA approved for vision correction. It's just trying to achieve different types of vision correction.
I'd like to kind of bring this back to a little different level. We're talking about the eye and what we're doing to the eye, but I always like to bring it back to what are we doing for the patient. And I think if we know about myopia management, we know that the earlier we intervene, the more effective we're going to be. So I guess I always like to use an example of a 7-year-old who's sitting in your chair and bring it back to your clinic. This kind of an example is a 7-year-old is minus 150. They have an axial length of like 24.1. A year ago at 6 years old, they were minus 50. And they had an axial length of 23.8. Okay. Now, when you bring it back to the patient's motivated, parents are highly motivated, they're worried about progression, and for any myopia management intervention, we need compliance. My experience is kids are very, very compliant with OrthoK because they love to see, and they know if they don't wear their lenses, they don't see, so they wear them. But I'm a big one, you know, with quality of life. They don't have to wear any correction. They don't wear that during the day, any correction. So I think to get back to the original question, would you prescribe OrthoK? Most definitely, yes. And I think OrthoK is the best intervention for a 7-year-old because I don't think they're great with soft lenses at that age. They have to be responsible enough to handle lenses and react to them and take care of them at school, if they ever get back to school. But, you know, if that parent is asking you, you know, okay, I'm concerned about myopia progression, I know you deal with this, how are you going to intervene to take care of my kid the best way possible? And I think certainly the first option is OrthoK in combination with atropine. You could do OrthoK alone and evaluate and add atropine later. Or in a 7-year-old, you could start with atropine only, but and just kind of plant the seed for OrthoK. But in any event, I don't think a soft lens is appropriate for that 7-year-old kid. And I'd like to see if you guys would approach that any differently.
I'll speak first. I look a lot at just the patient's maturity level and, you know, the parent's comfort level. And if I feel like the kid is not going to be able to handle contacts, soft or OrthoK, I will start with atropine. But yes, I always am trying to plant that seed of, okay, well, let's get him comfortable with this. And then, you know, if a year from now he's more mature and wants to start doing contacts, then for sure we'll jump into that. And I do talk a lot about the quality of life with the OrthoK. I think that's a really good point to bring up, Michael, because especially with my demographic and probably with lots of doctors who are listening to this, there's a lot of sporty kids out there. And to not have to worry about contacts during swimming or during a sporting event or, you know, fill in the blank, I think that's really wonderful. But also, to the point you made, if they're only doing OrthoK and they're only doing it at a time of day when their parents are around, the parents do have so much more control with that young kid over what's happening. A lot of my really young OrthoK patients, like 6 and 7-year-old kids, the parents are often doing the insertion of the lenses or of the molds for them for the first 6 months or a year, or whenever that parent feels like the child is old enough for them to relinquish that part of it to them. And so that's a really interesting point that you made there. Soft lenses, yeah, if we're in a daily disposable, those are, you know, usually fairly safe, but soft lenses are not the same as the materials that we use to make our OrthoK molds, and there are some risks that go along with that.
Yeah, just to chime in on your question, Michael, I think for me personally, I tend to think of soft contacts as the least valuable of the tools, but nonetheless, it's a tool. I think it might come to the forefront of discussion maybe more often now with the FDA approval of having a soft contact lens for myopia control. But ultimately, because of the limitations of it that I stated earlier, it's not my first pick. But I have to balance that out with patient expectations and motivation, you know, because orthokeratology tends to be a definite procedure. It's a fitting process. You know, there's a lot of time involved on the patient side of things. If that motivation isn't there, that's sometimes the only time that I'm perfectly fine going into a soft lens from the patient's benefit. But at the same time, I mean, it is our responsibility to get the patient and the parent to understand why we're motivated about this. So hopefully they can share that and make a more educated decision. But ultimately, I find that a lot of people respond well to that. It's just there's a few that they just want the simple, clean, and done. And in my opinion, doing a soft lens is not my first choice, but it would be better than doing nothing. They're not.
I think it is really important, though, also to make sure that we have I think it's important to make sure we have that compliance discussion with them. If they are wearing that soft lens, they have to know that it's not 50-50. You don't wear your glasses half the time. You have to wear that soft lens almost every day, with very few exceptions.
I think
All right, looks
each
like
of us is a little bit biased because we like OrthoK. We've had good experiences with it, its success, and gotten great feedback from the patients. But people who are not used to fitting GP lenses, are not trained in OrthoK, are going to fall back on that soft lens and say they're doing myopia management. And I don't know, I'm a little concerned about that. So.
Well,
In some cases it's working great, but it is more narrow. Like, yeah, a certain number of patients are going to do great with that, but when you have that patient that is not stable in that soft lens modality, it's great to have the tools to say, okay, we have something else we can do.